Good evening, Raghunath sir.
Good evening, Doctor. How are you?
Good, sir. How are you doing?
Good, ma.
Yeah, the
I don't know,
PG
because
Sri Shail has
Wednesday
joined
I
in.
closed my clinic for quite some time. All Wednesdays are having some or the other appointments.
Too many programs, sir. I think everybody's overwhelmed with the number of programs BPS is doing.
Yes, there's too many programs, and it is a good thing that Basavaraj and Madam Rupa Bella have initiated such a good thing. But of course, too much is too bad also. We need some time for entertainment.
Yeah. Next, we should plan some major entertainment in the upcoming Pedicon, I guess.
Yes, yes.
Sri Shail?
Huh?
Good evening, sir.
Yes, ma'am.
Good evening, sir.
Good evening, ma'am. Good evening, sir.
Sri Shail, you can try sharing your slides and see by the time everybody joins. Good evening, Ravichandra, sir.
Yes, ma'am. Yes, ma'am.
Prahlad Guru, good evening. Photo Torsi.
Prahlad, sir, good evening. Yeah, we can see Sri Shail.
Yes, ma'am.
Good evening, Madhu, sir. Good evening, Prahlad, sir.
Good evening, madam.
Good evening, Madhu. How are you?
No.
Good evening, sir.
Sri Shail, you can stop sharing the screen. So once
Okay,
the introduction is over and when sir tells to project the OSCE, at that point of time, you can start projecting the OSCE.
Okay, ma'am. Okay, ma'am.
Hello, good evening, Dr. Raghu. Can you see me? Dr.
Oh,
Ravi?
yes, Sabre.
Good evening, Dr. Suman.
Light opposite
Good evening, sir.
ಕೂತಿದ್ದೀರಾ ಅನ್ಸುತ್ತೆ.
Dr. Madhu. Good
Hello, sir.
evening.
Good evening, sir. Ravichandra, sir. Good evening. Namaste.
ಅಷ್ಟೇ ಕಣಪ್ಪ ರಘು ಬ್ರೈಟ್ನೆಸ್ ಏನ್ ಮಾಡಕ್ಕಾಗಲ್ಲ ಅಡ್ಜಸ್ಟ್ ಮಾಡ್ಕೋ ವಾಯ್ಸ್ ಕೇಳಿಸುತ್ತಲ್ಲ
Voice is more important than.
ಅಷ್ಟೇ ಓಕೆ ನಮ್ಮ
All of them know you very well, sir.
ಡಾಕ್ಟರ್ ರವಿಚಂದ್ರನ್ ಇದ್ದಾರಲ್ಲ ಅಷ್ಟು ಸಾಕು ಬಿಡು
Yes, sir. Yes, sir.
ಸುಮನ್ ಯು ಆರ್ ಲುಕಿಂಗ್ ವೆರಿ ಬ್ರೈಟ್ ಏನ್ ಲೈಟ್ ಜಾಸ್ತಿ ಹಾಕಿದ್ರಿ ಕರೆಕ್ಟ್
ಕರೆಕ್ಟ್ ಲೈಟ್ ಕೆಳಗಡೆ
ಹೌದು
ಲೈಟ್ ಆಗಿ ಕಾಣೋಣ ಅಂತ.
ಹೌದು ಗುಡ್
I think two more panelists have to join. 8:30
Fine.
sharp we can start.
Fine. Yeah. ಈಗ ASCII, what you are telling, Dr. Suman, what exactly?
Sir, I think Sri Shail, the PG himself, he has the OSCE in the first few slides.
Okay.
So I think Ravi sir or Srinivas sir, who will be reading first the OSCE?
Sir.
I think sir will be reading out the OSCE questions, following which the case will be started by Sri Shail.
Okay.
So I have also requested Sri Shail to ask his friends to join in, so that if any questions, which you are unable to answer, it can be directed to your friends as well.
That's fine. Yeah, instead of targeting only Dr.
Yes, sir.
Sri Shail, so
Yes.
others also take the bullets.
IAP
Yes.
teaching, nobody is targeted, sir. It's very friendly.
Yeah.
That to Dr. Prahlad around, he will start teaching.
Yeah, it's a teaching only. It's
Yeah,
not
every
target.
time, even in the examination hall, he will be teaching. So we have to alert him, boss, this is exam.
What about the DNB results, sir? Any idea when it is going to come?
Raghu, when it will be? Because everything final is any moment it has to be expected, Dr. Suman.
Okay.
Usually
moment.
pediatric comes in the last. Sir.
Even the RGHS results are at any time it may come.
Yeah. Before RGHS only DNB got over, no?
Okay, sir.
So
Rupa madam has also joined in.
Good evening, madam.
Unmute.
Good evening, Rupa madam.
Unmute. Yeah.
Good evening. Good evening.
Good evening, Dr. Rupa, madam. Yeah, good evening.
Good evening.
Yeah.
Good evening, madam.
Good evening, Madhu.
Good evening, madam.
Madam, how was the surprise NMC inspection in your college?
You can imagine, no, Madhu? It
Oh, you
was,
had a surprise inspection, is it?
Yes, I had yesterday.
morning they just came to the area where we sign in the hospital. Then they asked one of the faculty in which department you are. She was medical faculty. So they said, Chalo, we'll go to your medicine wards. That's it. Like that, there were 3 of them entering into different areas suddenly at 9 o'clock.
This is for UG, ma'am.
Yeah, UG 250 compliance it was.
Okay.
They had come once and this was to the compliance. Yeah.
For increase of seats, isn't it?
Yes, sir. Yes, sir. Usually ಎಲ್ಲರೂ ಒಂದು ಐಡಿಯಾ ಇರುತ್ತೆ ಬರ್ತಾರೆ ಅಂತ ಬಟ್ ನಿನ್ನೆ absolutely I think
That is how it will be, madam, in future.
In future.
they have not stayed anywhere nearby. They directly flown in.
At least one day earlier they will inform usually, even though it is surprise, no?
Inform ಮಾಡಲ್ಲ ಯೂಶಲಿ ಎಲ್ಲರೂ ಹೋಟೆಲ್ ಬಂದ್ರೆ ಗೊತ್ತಾಗಿರುತ್ತೆ.
But what happens to people who have gone on leave, etc.? Are they accepting that?
Some of them they accept, sir, where there is an official thing, but mostly they don't.
Because they can't keep limbo. Everybody asks for leave, the personal requirements. So I find it very difficult to deny a person a leave. At the same time, I don't know when this Damocles sword will fall on us.
That is the risk we are at. Usually leave kodala, sir, unless it is very genuine. They are expecting the inspection. In our colleges, they don't allow us to go far away.
Sir, but if you have adequate staff in the department, they usually don't mind, sir.
But still, Madhu, usually inadequate irutte.
Baswaraj sir has joined.
Usually senior residents are also inadequate.
Okay. This is
Good evening, Dr. Baswaraj.
Nagbhushan sir also connecting, I think. Hello, Dr. Baswaraj, you can unmute and speak. Good evening, Dr. Subbarao sir, Dr. Baswaraj, Dr. Nagbhushan sir.
Good evening to all. Priya.
Good evening, sir. Good evening.
Good evening.
Ravichandra sir, good evening. Good to see you.
Sir. Good evening to all, sir.
Good evening, sir. Good evening.
Good evening, sir.
Good evening, sir.
good evening.
Good evening, Nagbhushan sir. Good evening, Subbarao sir. Good evening, Priya ma'am.
Nagbhushan sir. Good evening, sir. Subbarao sir. Good evening.
I think
Priya,
most
good
people
evening.
only are
Good
joining.
evening, good evening, sir. All are telling good evening, sir.
Subbarao sir, good evening. ಆಮೇಲೆ ಮತ್ತೆ ಸರ್ ಏನು ಮಾತಾಡ್ತಿಲ್ಲ ಅನ್ಬೇಡಿ.
ಗುಡ್ ಈವ್ನಿಂಗ್ ಗುಡ್ ಈವ್ನಿಂಗ್.
ನಾವು ಮುಂಚೆನೆ ಹೇಳ್ಬಿಟ್ಟಿದ್ವಿ ಗೊತ್ತಾ ಸರ್, ನೀವು ಹೇಳೋದಕ್ಕಿಂತ ಮುಂಚೆನೆ.
ರಿಪೋರ್ಟಿಂಗ್ ಸೆಕೆಂಡ್ ಹ್ಯಾಂಡ್ ಸ್ಪೀಕರ್.
ಇಲ್ಲ, ನಾವು ಫಸ್ಟ್ ರಿಪೋರ್ಟ್ ಮಾಡ್ಬಿಟ್ಟಿದೀವಿ ಆಲ್ರೆಡಿ.
ಸ್ಪೀಕರ್ ರಿಪೋರ್ಟಿಂಗ್ ಅಲ್ಲ, ಸ್ಪೀಕರ್ ಸೆಕೆಂಡ್ ಹ್ಯಾಂಡ್.
ಸ್ಪೀಕರ್ ಈಗ ಮಾತಾಡಲ್ಲ.
ಎಲ್ಲ ಫಸ್ಟ್ ಹ್ಯಾಂಡ್ ಸ್ಪೀಕರ್ ಪ್ಯಾನಲ್ ಫುಲ್ ಇದಾರಲ್ಲ, ಅದಕ್ಕೆ ನಾನು ಪ್ಯಾನಲಿಸ್ಟ್ ಆಗಲ್ಲ ಅಂದೆ. ದಿಸ್ ಸುಮನ್ ವಿಲ್ ನಾಟ್ ಲೀವ್ ಮೀ. ಐ ವಾಂಟೆಡ್ ಟು ಬಿ ಅನ್ ಅಟೆಂಡಿ ಓನ್ಲಿ.
ಇಲ್ಲ, ನೀವು ಲಾಸ್ಟ್ 2 ಟೈಮ್ ತಪ್ಪಿಸ್ಕೊಂಡಿದ್ದೀರಿ, ಅದಕ್ಕೆ ಸುಮ್ಮನೆ ಹಿಡಿದ್ಬಿಟ್ಟು ಇಲ್ಲಿ ಹಾಕಿದಾರೆ.
ಬಸವರಾಜ್ ಅಲ್ಲಿ ವಿಡಿಯೋ ಆನ್ ಮಾಡ್ತಾ ಇಲ್ಲ. ಬಸವರಾಜ್ ಬಿಸಿ ಇದ್ದೀರಿ?
ಯಾರ್ದು ಇವತ್ತು ಕೇಸು?
Respiratory.
ಯಾವ ಯೂನಿಟ್ ಕೇಸು?
Yes, sir.
Whose case is this?
Sir, this is MBJ, sir.
MBJ, okay.
MBJ.
We have another 2 experts to join in. I think Dr. Srinivas is here. I think. Good evening, sir.
Good evening, Subbarao sir.
Good evening.
Prahlad sir, Rupa
Good
ma'am,
evening. Yeah, Dr.
Ravichandra sir.
Good evening, please.
Srinivas sir.
ಇದು PG ಚೆಕ್ ಮಾಡಿದಾರ ಸ್ಲೈಡ್ಸ್?
ಚೆಕ್ ಮಾಡಿದ್ದಾರೆ. ಆಡಿಯೋನೋ ಚೆಕ್ ಮಾಡಿದ್ದಾರೆ. ಗುಡ್ ಈವ್ನಿಂಗ್ ನಾಗಭೂಷಣ್ ಸರ್.
Good evening, sir. Nagbhushan sir. Good evening, sir. Srinivas sir. Good evening.
Good evening, sir.
Good evening, sir. Nagbhushan, sir.
Nagbhushan, sir, are you able to hear us? Good evening, sir.
Sir is not hearing.
Or cares? Yeah. Good evening.
Well, just call Varsha ma'am once.
Yeah.
I have a question for every one of you. And that question is, if somebody comes into the panel for the second time within 4 months, should he not host a party?
Definitely, sir.
Sir, it's targeted to you only.
Hello, sir. Good evening, sir.
Is PGs have been told to join?
Yes, sir. I've told, sir.
The question is to Dr. Prahlad.
I'll tell them, sir. Once again, I will tell the assistant. Okay.
Should we host or should Prahlad host it?
Sir, Prahlad is calling all of us to Indira Gandhi, sir.
Sure, sir. Always welcome, sir. Our Indira Gandhi is always welcome everyone. Anytime you can come, we'll host, sir. No, not an issue at all. It's our pleasure for the expert and genius professors. All of you are welcome, sir. Always.
See, I knew that. That is why I asked that question. Thanks, Prahlad.
You should not ask the question, sir. You should demand.
No. We want everyone to know. We want everyone to know your magnanimity, no?
It's because of the institute.
A discussion, ma, Suman?
Sir, ma'am, it's a case on respiratory distress, a child with respiratory distress. The PG is from MV Jairam Medical College.
The number, like which case discussion agide?
This is the seventh, ma'am, seventh case.
Okay. Thank you.
I think next will be from JSS.
Yes.
Dr. MD Ravi.
Yes, sir.
Yes, sir. That's correct, sir.
Nice to see Raghunath after some time.
Sir,
he was busy with the intensive care chapter conference.
Yes, yes.
Actually,
also,
we are having all the conveners for the first time, I think, sir. All four of them with the Suman.
Together, yeah.
Good evening, Kamta, sir.
I know.
Good evening, Mahesh, sir.
Hello.
Good evening, sir.
There was some ceremony of his parents' 50 years.
Yes,
Marriage.
So, congratulations, sir.
Thank you.
Please convey our wishes.
Sure,
Sir, 8:30. Shall we start?
Yeah, please.
Yes. I'm starting.
1 minute, sir. I will.
No, we will start with the introductions, by which time they can join.
So Varsha ma'am told she'll be joining any moment.
Yeah.
Meanwhile, I think Professor Subrav is there. Professor Srinivasan also said he will join.
Yes, sir. Sir will join, he said.
Yeah, I have sent the links to them. He is so particular. Last Wednesday, he said, where is the link?
Yeah, where is the link? Today also he was asking then.
So I said, sir, it is once in 2 weeks. If he can be so enthusiastic to learn, I think it is a lesson for all of us.
It's okay.
Sir, I think we should start.
Yes, let us start. Start. Askis are ready, no?
Yes, sir.
Shall I start or?
Yes, sir. Yes.
Good evening, everybody. We welcome all of you to today's PG teaching program, which is the 7th in the session. And this has been the brainchild of our Dr. G.V. Basavaraj and Rupa Ballad Madam, which has been supported by Priya Shivali, our able secretary, and Manisha Madam. So today's program is mentored by Professor Ravichandar sir, who is well known in the IAP circles. He is a professor and principal at MBJ Medical College Hospital, and he has a vast teaching experience, about 34 years of experience at Armed Force Medical College, and his teaching stride is still, and he is pursuing his still teaching right. And he is a very good examiner. He has been examiner for many of those postgraduate as well as super specialty programs. So we welcome Dr. Ravichandar sir.
Thank you very much.
And we have the panelist, Dr. Varsha Suresh Ahirao, who has done her MBBS from Seth Medical College, KE and KM Hospital. She is presently working as professor and head of unit Department of Pediatrics, MBJ Medical College. And she will be the one of the experts. Dr. Prahalad Kumar.
Welcome, Dr. Varsha.
Thank you, sir.
So Dr. Prahalad Kumar is a professor of pediatrics and head of the pediatrics department at Indira Gandhi Institute of Childhood. And he's also a very good and well-known teacher in the pediatric groups. We welcome you, sir, and he's a very good friend of mine. It's an honor to welcome you around, sir.
Thank you.
So,
thank you.
We have Dr. Srinivas K as one of the experts who's done his MBBS from MMC and presently working as professor and head of unit Department of Pediatrics, MBJ Medical College. We'd like to welcome all the postgraduates on board, and we also welcome the president of Pediatrics, president of IAP Karnataka, Dr. Rupa Ballad, and over to Dr. Rupa Ballad, madam.
Hello, good evening, everybody.
Good evening.
All the respected faculty experts who have here to discuss the case. Thank you very much for accepting and being here with us. Dr. Ravichandar, Dr. Prahlad, Dr. Varsha, Dr. Srinivas. Welcome you all and thank you again. And this is such a good program. This program of postgraduate teaching has taken up very well. I would like to thank Dr. Nagbhushan sir and the other conveners who are constantly behind this program to see that it is successful and it is conducted in a very meaningful way, so that there's a lot of learning happening, not only to the postgraduates, to also all of us who are into pediatric practice. Thank you, sir, and thank you everybody, all the conveners for this. Without taking much time, I would like to thank again for giving me this opportunity, Dr. Priya and others. Thank you very much.
Over to Dr. Basuraj GV, who is the president of Bangalore Pediatric Society. Dr. Basuraj.
Thank you, Dr. Raghunath. The network is an issue. That is why I'm not switching on the video. So thanks to Dr. Rupa Ballad Madam, Dr. Manisha Bandharkar, our Karnataka State President and Secretary. Of course, this is a scientific program which is well conceptualized by none other than our chief scientific convener, Professor Nagbhushan sir, along with the Dr. Suman, Dr. Madhupuja, Dr. Raghunath, and Dr. Vinod and all the other faculties. Today's faculty, which is led by none other than Professor Dr. Ravichandar sir, along with Dr. Prahalad Kumar, Dr. Varsha madam, and Dr.
Srinivas.
Professor Srinivas sir from MBJ Medical College. So really it is in a very, very interesting session. So looking forward, of course, I recognize the presence of our none other than Professor S.T. Subrao sir and Dr. Srinivasan sir is always enthusiastic to be here. And our dynamic secretary, Dr. Priya. So she's coordinating so well to take the academic program to the nook and corner of our country. So with these few words, wish you all the best for this program.
Sorry, I have forgotten the important person for today's session. It is Dr. Srishail. Yeah, Srishail AJ is a postgraduate from MBJ Medical College. Sorry, Srishail, for introducing you last, but it is not the least. You are the main person today. And over to Dr. Srishail and Dr. Ravichandar sir.
A warm welcome to all the panelists and distinguished people on the board who are watching this PG presentation. a humble presentation from MBJ Medical College. Of course, it's a small, short case, but of course, there's a lot of learning points from this case. I think without much ado, I think we can start with the proceedings. I think the first thing is the OSCEs which come up. I request Dr. Srinivas to present the OSCEs.
Yes, 1 minute. Yeah. So can you go to next slide? So this is the one picture. Then in this, like you want to know. So
just give it a few seconds and then go to the next questions.
Okay.
You can go to the questions.
Next slide. Yeah. So this identify the study in this picture, and then identify the clinical pattern in the study, and give example of these conditions. So just you can answer all these questions in the chat box, and then we'll discuss all these the questions in the next after the clinical presentation. Next slide, ma'am. Yeah, next. So this is one Excel picture. The diagnosis of this condition and most common cause of this condition in older children and teenagers. What's the most common cause? The second question. The third question is the name any 2 complications of this. You can keep answering in the chat box so that we'll discuss this later.
Yeah, I think we'll proceed with the case presentation. Dr. Srishant, you can start.
Okay, sir. Good evening, everyone. This is Dr. Srishant, second year postgraduate. Will be presenting a case on approach to a respiratory distress in a child.
Dr. Srishant, just a minute. All the postgraduates in the attendees, there will be a panelist update link sent to you. Please press yes and become as panelist. Otherwise, you will not be seen in the panel. And Srinivasan sir, please upgrade yourself. I request Kushi to send the request once again.
It's where, madam? Where in the missing chat box? Huh?
No, it will pop up when they are in the attendee list. It will not come to us.
Okay.
It will pop up in their screen. You can go ahead, Dr. Srishant.
A 1-year female child named Dutushri, hailing from Hoskote, informant his father, who is reliable, admitted on 9th of March at 5:50 a.m. in the morning. Child presented to us with the complaints of cold and cough since 1 day, complaints of vomiting, 2 episodes, hurried breathing and chest indrawing activity 4 hours prior to admission.
So go ahead.
Yeah, go ahead.
History of presenting illness. Child was apparently all right 1 day prior to admission when the child developed cold in the form of running nose. History of cough, which was dry type of cough. No medications were taken. History of consumption of rice with ghee at 8 p.m. at home. Around 4 hours after consumption of the same, the child had 2 episodes of vomiting containing food particles, large in quantity, non-blood tinge and non-bile stain.
Yeah.
Followed which a child developed increased bouts of cough associated with hurried breathing and chest indrawing. Since then, the child was lethargic and not feeding for around 4 hours till they got her to the emergency.
Yeah.
No history of noisy breathing or a change in voice, no history of fever, no history of rashes, no history of loose stools, no history of seizures.
I request my co-panelists, they can start questioning about present history.
Okay, Shrishal, this child was apparently healthy prior to the onset of illness. Okay.
Yes, ma'am.
And just started with all this complaints. So first
Yes,
thing,
ma'am.
which system do you think is involved?
Ma'am, according to the history, ma'am, most common the cough, cold since 1 day, ma'am, and vomiting and hurried breathing and chest indrawing is indicative of all respiratory complaints, ma'am. The respiratory system is most involved in this, according to the history, what the father has given, ma'am.
Okay, because child started with the
So
cough
with
and
cough,
you
cold,
think of respiratory system.
respiratory system.
Okay, and the next day child started with the hurried breathing, chest indrawing. So what do you think? Which can you localize? Where is the lesion? Where is the problem?
Ma'am, based on the history, like her child has cough and cold 1 day prior to that, ma'am. It is a viral illness, a viral respiratory illness, which has progressed to severe form, ma'am, which was involving a lower part of the respiratory tract, ma'am. Could it be a lower part of the respiratory tract, ma'am?
What history in this point out that it is a lower respiratory tract involvement?
Ma'am, hurried breathing and chest indrawing, ma'am, and decreased activity. Both all three suggestive of lower respiratory tract infection, ma'am.
Okay.
No, need not be always, is it not? Hurried breathing, chest indrawing can be there even in the upper airway also. Okay. So first, yeah, as pointed out, it should be upper or lower
respiratory.
Whether it's a primary respiratory problem or some other system is involved, which is leading on to the primary and secondary involvement of the respiratory problem. So for that, we have to analyze.
Analyze. Yes, sir.
So you said most probably it's a viral
infection.
Is it not? So what are the factors which is pointing towards the viral infection in this condition?
In this condition, cough and cold 1 day prior to that onset of hurried breathing and chest indrawing is indicative of viral illness, sir.
But viral illness, I can put it on the other way. It could be just an allergic rhinitis or allergic rhinitis, which can give rise to the cold and cough also, is it not?
Yes, sir.
Yeah.
What other symptoms will suggest of this viral infection?
A fever, cough, cold, and conjunctivitis might be the symptoms, sir, which can progress towards like viral, like which goes towards viral illness, sir.
Any other symptom other than this thing?
And involvement of multi-system also can cause the viral illness, and similar complaints in anyone in the family also can indicate of this viral illness, sir.
Most important pointer here is any viral illness causing this much of respiratory distress and problem, invariably fever will be the one of the important manifestation. That is missing here. Is it not? So that is a pointer to be considered. Why fever is not there, or the parents are not
noticed. Parents might have not noticed the fever.
For example, the fever can be a mild fever. So which are the condition of upper respiratory tract involvement will have a low grade fever?
Could it be normal pharyngitis also, sir? And tonsillitis also can also have mild fever.
This child is a 1 year. We'll confine to this 1 year old child. 1 year old child expect tonsillitis, pharyngitis. This 1 year old child. We'll stick on to this case.
Tonsillitis are common in the school-going children.
School-going children, sir.
I'm pointing towards 1 year. We'll restrict to this case. 1 year old child. What are the causes?
Sir, could it be 1 year like age we are taking consideration? Could it be bronchiolitis also, sir? Bronchiolitis also can have fever, milder form of fever. Then acute laryngotracheobronchitis, like croup also can have milder form of fever, sir.
Shrishai,
sir.
First and foremost is you are talking of a child of 1 year.
Yes, sir.
What common morbidities with these children of infants have commonly at this age group? Then only you can think about other things. So about the common morbidity, that's a routine day-to-day practice in OPD. What do you get of children, infants of 1 to 2 years? Common.
Sir, cough, cold, could it be upper respiratory tract infection also, sir? Could it be bronchiolitis also, sir? Then could it be pneumonia?
I'm not coming to very specific diagnostics. Yes, common in this age group is viral infections or common.
Common, sir.
Okay, so what is not fitting into a viral?
The fever was not there, sir. Fever history is fever history is not there, sir.
Can you distinguish based on the fever? It could be a viral, though there's nothing sacrosanct about it. Distinguish between viral fevers coming in as well as bacterial fevers coming in. How do you put it across?
Sir, viral fever usually will be high grade, sir, and bacterial initially start with low grade and progress to high grade, sir.
And in different profile, you have to distinguish. Bacteria starts slowly rise up, viral starts high and comes down.
Comes down, sir.
Important step, of course. You have to think about cohorting of these cases. You told it, but you have not explained. If I find that more number of children in the house or adults, and then you have to tell them, that is why I think about viral. Since you have got no fever at all, why are you thinking about infection? You said infection. When I say infection, straight away we start writing 2 antibiotics, 3 other drugs, etc. So we have to be very careful in telling infection. What are the pointers to tell you that this child has got an infection?
Sir, decreased activity is one thing, sir, which is making worry here. And one more thing is vomiting, sir. Vomiting also might suggest you of infection, sir. Decreased activity might be sepsis in this age, sir, up to 1 year of age, sir.
Listen, Dr. Shishail, it is indicating maybe the severity of the illness, may not be the infection. You should ask the pointer to Dr. Ravichandran, clearly ask what are the pointers and say it's an infection. He is not asking a severe form of infection. If it is a severe form of infection, for example, severe pneumonia, bacterial pneumonia, then your pointers are well taken. Or even the severe form of viral infection, your pointers are well taken. He is giving, and we are also saying, we have to be very clear in our thought. First thing, whether it's an infection or not. If it is not, so then you can go ahead with the other side of the case. Okay, so that's what you have to dissect it out. That's an important thing. That's why Dr. Ravichandran has given you this case. Okay.
And,
right. Yeah.
So talking of vomiting and a child having cold and cough, is vomiting very important? Because is it not a very common manifestation for a child to cough and vomit?
Yes, sir. It indicates the severity of the disease, sir. Like following post-tussive vomiting will indicate the severity of the disease, sir. And in this age group,
does it tell anything? Why does vomiting occur?
Might be due to GERD, sir. GERD, sir.
GERD means it may not be vomiting of that day, no? It will be there. He'll have a history, multiple episodes of vomiting earlier. He had a cold and cough.
Okay, we'll come to you. How the GERD will manifest, Shishail. Okay, we'll come to your findings. So, if you're thinking of GERD, does it come with a cough and cold?
No, sir. Initially, they'll have a complaint of vomiting, sir. Then later they'll develop cough and cold, sir.
Vomiting may not be a manifestation of GERD.
GERD manifests with only cough.
What are the other manifestation of GERD? How it will present? Unless you know that, then only we can proceed with this case. That's an important contributor for this case. So what are the manifestation of GERD in a young infant? Come on, others can answer. Dr. Priya, others can chat in the box. No, you can, other postgraduates. If Srishaila cannot answer, Dr. Srinivas.
Yeah, sir, I'm checking, sir.
Check my.
Srishail, when you think a child is having GERD.
Yes, ma'am.
Well, when you think of the child is having GERD,
child will come with which symptoms? Then you'll think, okay, this child might be having GERD. What are the common symptoms?
Common symptom in an infant. We'll stick on to
infant,
the
yes.
infant. Yeah.
There will be a excessive cry, ma'am, irritability, and then feeding issues will be there, ma'am. Like for mother, as a mother point of view, there will be she would have fed the baby and she would have not burped, and which could have lead to GID, ma'am.
Others, any other postgraduates?
I don't say no.
Yeah. Other postgraduates, please.
Divya, can you unmute, please?
Chat box.
How they will see, usually Dr. Ravichandran has given you a small infant. There could be initially there could be regurgitation of feeds, maybe there. Regurgitation of face, arching of the back, recurrent cough and recurrent wheeze, is it not? And which
Yes,
recurrent cough and recurrent wheeze and recurrent aspiration pneumonia like symptom.
Not an acute condition, first of all. GID, I'm not saying
It's not
all
yeah.
one day.
Is it not? That's how you should take it. So when the child comes to you with recurrent cough or recurrent wheeze or recurrent aspiration pneumonia like then with this arching of the, then we can think of GID. Is it
GID. Yes.
So that's how you should. They will not come as a vomiting as a first presentation.
We will take the next symptom in consonance with cold, cough, vomiting, and he had hurried breathing and chest indrawing. We put these three together. Now, what are your thought process? He had a cold and cough, which seemed to be okay. He just vomited 2 episodes, and then he had hurried breathing and chest indrawing. Could you put them together and come to some sort of a pathogenetic conclusion?
Sir, according to the history, there was a consumption of food at around 8 o'clock with rice and ghee. He had a preceding viral illness which has caused this vomiting, sir. Vomiting, and a child has vomited, and after 4 hours, the child has had a vomiting, which was large quantity. Whatever he has taken, he has vomited, sir. And later following that, the child has developed distress. Because of this, considering these events, child could have been aspirated whatever, like some amount of food what he has taken, sir.
Are there any indicators to tell that this is a vulnerable child for aspiration?
Sir, age group only, like 0 up to 2 years, so there are more chance of aspiration, sir. Age group, and it was age group taking into consideration age group.
Do we see so many children in our OPD or emergencies of children? See, vomiting is the most common symptom in children. It's a very nonsense symptom. But you don't get so many aspirations into your system. So what are the conditions which make them vulnerable for aspiration?
You got the pointer, no? There should be, see, normal child cannot aspirate. Normal conscious child cannot aspirate, is it not? So that's why
yes, sir.
Dr. Ravichandran has given you a clue. What are the predisposing factor for aspiration?
The history also you mentioned, no? This is a complaint of decreased activity. So is there anything like activities, consciousness, anything was altered?
Was the activity following it or preceding it?
Preceding decreased activity history was not there, sir. After the hurried breathing and chest indrawing, the activity has been come down, sir.
Okay, so what are the, just only, they may not be applicable to your kind, but children, if they come with this sort of thing, they have a higher chance of aspiration. What are those conditions? Either in the oropharyngeal or in the esophagus or in the stomach or in the tracheal pathway? What are those conditions which can predispose them to aspirations?
Or CNS involvement, yeah.
Consciousness involvement.
Like, sir, predisposing condition, we can take like a tracheoesophageal. If it is operated case of tracheoesophageal, they might have chances of getting aspiration, sir. And
we'll put it broadly: esophageal disorders.
Esophageal disorders.
Mechanical or
esophageal disorders. And then respiratory, if we come to know, like, could it be a cystic fibrosis also, sir?
No,
Which
don't go straight away. See, anatomical disorder you said, tracheal and esophageal, oropharynx you see, anything cleft lip, cleft palate, is it not?
cleft lip, cleft palate also, sir.
Like that you have to go from the oropharynx, then down tracheoesophageal fistula, GRD, GERD, is it not?
Yes, sir.
Then oropharyngeal, in coordination.
In coordination and
very important.
Neuromuscular disorders, like you have seen, no, so many cerebral palsy children.
CP children, sir.
Why they will have a decreased oropharyngeal
palatal movement. Yes, sir. Palatal
so like
movements.
that, suppose a muscular dystrophy, SMA child.
Yes, sir.
No, is it not? They cannot
Yes,
able
sir.
to swallow, chew properly. So their chances are aspiration like that. That's the question. You should be. That's what Dr. Ravichandran is asking. Any predisposing factors.
This child is having decreased activity. Do you feed a child if he's unconscious or having lethargic? Do you feed them?
No, ma'am.
Why don't
No,
you
ma'am.
feed them?
Chances of more aspirations, ma'am.
Okay. So they are predisposed? Yes.
Yes,
If the
ma'am.
child is having respiratory distress, is very much tachypneic, will you feed
Yes.
them?
No, ma'am.
You keep them NPO, right?
Yes, ma'am. Yes,
Keep them
ma'am.
NPO.
Which can aggravate even after feeding which can aggravate the distress, ma'am. A child will have that.
Why the distress will be aggravated? What you are worried about? Most of the time they might not feed because of the severity of the illness. But even if they're able to feed, you keep them NPO, right? So what
Yes,
you are
ma'am.
worried about in them? You're worried about what we are discussing?
Aspiration.
Yes.
We should tell, no? Is it
Aspiration.
For aspiration, you have covered all the three areas. That is one, oropharyngeal coordination, esophageal motility as well as obstruction, and gastric returns. Fourth, of course, is will come in terms of
neuromuscular.
And last, of course, will be the position also.
Position.
The child is sleeping most aspiration. The child is in a sleeping position. Suppose the child is sleeping and the child is vomiting. There's no place for the vomiters to go. Where it has come from. So all these are important. That's what you get a history like this. You have to ask these questions or find out if these are also involved in it. Now we come to the last of your major symptom, that is, child after all this has decreased activity. What is the cause?
What is the cause? Why the child become decreased activity?
This is following hurried breathing and chest
drawing. Yes.
So what it leads to what? Which lead to decreased activity?
Child could have been aspirated and his sensorium has been child has become sensorium has been reduced, ma'am. After vomiting.
No. You are don't be prefixed, okay? Knowing the diagnosis. You should analyze why the child become lethargic, means whether the baby is become exhausted,
hypoxic, sir. Exhausted and hypoxic, sir.
So, which is the most important bottom line for respiratory disorders? Now I can ask you that question. Most important bottom line of a respiratory disorder. Understood?
What? No. What is that? Respiratory means what? What you take, what you leave out. Simple.
We take oxygen and carbon dioxide, sir.
Correct. Function of the respiratory system is to get oxygen in.
Oxygen.
So any respiratory symptomatology, if it causes
hypoxia, there will be
know that it is a severe disease of whatever nature, whether parenchymal, airway, whatever it is. Okay.
On the other hand, what are the symptoms and signs of respiratory distress? Then respiratory failure. So that you should know. Okay. Fine.
So, has this got any impetus or impact on the way you assess a child coming with cough with fever in the light of the ARA symptomatology?
Yeah.
You got my question? In the ARA symptomatology, you've got three main things. Child should have cough with fever. Second is?
Hurried breathing, chest in drawing. Is it not?
chest indwelling. Fourth is?
Yes, sir.
Not feeding well, lethargy.
Where it is fitting into?
Sir, it's fitting into very severe pneumonia condition according to the ARI classification, sir.
Yeah,
only thing is it doesn't have a fever.
The fever history is not there, sir.
Correct. Okay. Can we go? Anybody else wants to ask a question? We'll go ahead.
Yeah, before that, okay. So since suppose a child had mild fever, so what are the common condition you can keep it in mind?
Fever. Mild fever.
Mild fever, high grade fever, both will take together for the completion sake.
Child had fever means one could be based on symptom.
With this background, you
Sir,
got in this
yes,
infant, suppose a child has fever, one is low grade fever, another is high grade fever. So where you fit in this child? Come on, quickly.
Sir, first fever, low grade fever, we couldn't fit it into pneumonia, sir. Very severe pneumonia. Then second one, could it be
very severe pneumonia? 1 year old child definitely will have high grade fever.
High grade fever, sir. And milder form of fever could be the croup, sir, or and acute epiglottitis might be there, sir. And distress is there, fever is there. High grade fever they will have usually, and child is lethargic also. It can fit into epiglottitis, sir.
So one is croup, okay. Croup is aggrade, is it not? So
yes, sir.
To say it is croup, what is missing here? What are the 3 important symptoms of croup?
Sir,
okay, I'll straight.
Noisy breathing is not there, sir.
What is the type of cough they will have? Croup.
Barking type of cough, sir. Usually they'll have barking type of cough. So brassy or a barking type of cough, sir.
All group will have barking type of cough, or some of the group will not have a cough at all. You'll be coughing, but no sound is coming.
There will be change in voice, then noisy breathing. That could be a stridor also, sir.
Rashishal, my question is very specific. Among the disorders, in which group you may not be able to hear the sound at all?
Sir, infectious group, sir, where you can't able to hear.
See, groups are there. Okay. See, if you've got a very severe epiglottitis, where is the air to come out from? Okay. Or do you know the mechanism of cough? Why cough is there?
It's a defense mechanism which is regulated in the medulla, sir.
Okay. And what is the speed with which object is ejected? Just for this is for trivia. If you know, you tell. To
expel whatever for whatever particle or a foreign body which is there to
speed at which it is impelled. 2/3 velocity of sound. Sounds this one is 60 meters per second. Okay. So if it has to have that space to come out, that's why in a group, in an epiglottitis, there's hardly any air to go in or come out. You'll not be able to get sound. It's always called the aphonic cough. Now we have got all the symptoms. Now give me a tentative diagnosis to go by. Because we'll develop the diagnosis as we go by. Tentative.
So with at history level only, just to give that tentative diagnosis.
We'll go with the next slides of your past history and all after subsequently.
Sir, based on the history, cough, hurried breathing, chest indwelling, and vomiting, cold cough, could it be a could it be a bronchiolitis, sir? In no history of fever is there in this child, and
problem is when you want to make a diagnosis, first I should know how is the system involved. System involved. How is it involved?
Sir, respiratory system is severe, sir. Based on hurried breathing and chest indwelling. Most lower respiratory tract is involved more, sir.
I'm not asking you so how is the system. They got into respiratory failure, no?
Yes, sir. Hurried breathing, chest and decreased activity.
Rapidly progressing respiratory.
Rapidly progressing.
So, which are those conditions which can progress to respiratory failure very
rapidly?
Based on history, could be the aspiration pneumonia, sir. As a child had history of feeding and all. Second diagnosis could be a foreign body, sir. Foreign body. And third could be the hyperreactive airway disease also could be there, sir. Sudden onset of respiratory distress, sir.
First episode very unusual, but okay.
Unusual. Sir, the fourth could be the cough, cold, and the
Common condition you see in the emergency room or OPD, no? Rapidly progressive, what all the condition you should keep in mind in addition to what you have said. Quickly.
Foreign body.
Over. Foreign body over. Aspiration is over. Okay. Could it be croup can go rapidly?
Yes, sir. Yes, sir. Croup also can go, sir. Rapidly.
Could it be bacterial tracheitis? Could it be acute epiglottitis? Could it be acute severe bronchiolitis? You should mention.
Sir.
Could it be severe bacterial pneumonia?
Yes, sir.
So
Yes, sir. Yes, sir. Rapid progression.
So
many conditions can is this one. So we keep your minds open. Though we'll put infections a little down below because we don't have a fever.
Fever focus.
Okay. Yeah.
Okay.
Go ahead.
And for the completion sake, all the postgraduates should know what are the different types of cough depending on the airway involvement. And as Dr. Ravichandran has asked, the mechanism of cough and which are the condition airway where cough may not be a symptom at all. So you should know all of you. Okay, we'll go ahead. We'll come for the want of time. You can read up. Fine. Great.
No history of noisy breathing or change in voice. No history of fever. No history of rashes. No history of loose stools. No history of seizures.
So in the exam also, always you should justify yourself. Instead of the examiner ask you, so why did you ask for loose stools? Why did you ask for noisy breathing? Like that they will ask you. So in then and there you can justify yourself. So what type of noisy breathing? What exactly you mean by noisy breathing? You asked here, keeping in mind what? Like that.
Sir, history of noisy breathing, stridor and change in voice. Could it be in view of history of croup? I have asked noisy breathing and the change in voice, sir. Fever history to rule out it was infectious or not, sir, because we want to differentiate from other conditions like pneumonia and bronchiolitis bone present with a fever, sir, most of them, and rashes and loose stools in viral conditions, like it will involve multi-systems, sir, like rashes, and they may present with loose stools. And history of seizures due to hypoxemia, they might have seizures, sir.
That means seizure and red flag signs of severe respiratory infection. So I am in say classification. What are the red flag symptom or red flag signs of severe respiratory infection or acute severe pneumonia? Okay. So for that you are given no history of seizure. Any other symptoms you are going to add on to this? So like that it should be in the order. Okay.
Other than stridor, in this, are there any other noisy breathing thinking of?
Sir, V's could be the one more noisy breathing which their parents will tell. Some sound is making, the child is making. Could it be a V's also, sir?
When you say noise, what are the types of noises which are ominous? Ominous means, is a problem.
One could be the V's, sir. Second could be snoring.
No, you understand. Dangerous. Ominous. Yeah, sir. Ominous means it's a life-threatening.
Light-threatening. Or stridor, sir. One stridor. V's. Okay. Then grunting, sir. Then
grunting.
Very important. Somebody is put. Yeah, grunting. Somebody is. Very important. Yeah.
Grunting, sir. Then
what does the grunting indicates?
Sir, mainly alveolar pathology, sir. Mainly a lower respiratory tract involvement, sir. And it mainly due to the
mainly indicative parenchymal involvement.
Parenchymal involvement, sir.
Okay. No, but anything else? What does a grunt actually do in terms of mechanics, respiratory mechanics?
What is it? Why do they grunt?
They'll try infant or a child will try to forcefully breathe against the closure of the glottis, sir. To maintain the patency, sir, and there will be a
What happens? What it will do? It's a building up. What?
building up of the carbon dioxide, sir.
Not
not building up.
Sir, like retention.
Pressure, no.
Pressure, sir. Pressure.
To prevent collapse. It's like a CPAP, is it not?
Like mainly to open up the alveoli and to maintain the functional residual capacity, sir.
To prevent collapse. So
collapse.
Distending alveoli. Fine, you should make it simple. Fine. Okay.
Go to the next slide.
No past history of hospitalization, sir. History of nebulization taken twice on a OPD basis for cough and cold without hurried breathing and noisy breathing. However, no dramatic improvement was noticed. No history suggestive of atopy. No past history suggestive of lower respiratory tract infection, sir.
So very important here is you are given twice on OPD basis, cough, cold, nebulization. Without hurried breathing is okay, but why they are given nebulization? This is one of the important history.
What does nebulization achieve?
Why you give the nebulization? Nebulization is for what actually mainly?
Shaila, Divya, somebody is Prajwala. Anybody can ask because we cannot just take it for granted.
Which are the different condition you give nebulization?
Yeah, right.
Like hyperreactive airway disease also we can give a nebulization.
What nebulization you will give?
Like Livolin or Astalin nebulization, sir. Beta agonists, bronchodilators.
Where else you will give?
Like in bronchiolitis also we'll give, ma'am, like then 3% saline nebulization will give, ma'am, and then adrenaline nebulization also can be given, sir, on OPD basis. Then
or what?
For croup, ma'am, mainly for croups, ma'am, and then
Croup may not be recurrent. Okay.
Recurrent.
So what you are thinking here, whether it is a recurrent cause. This is a two important factor. For the discussion sake, there is no dramatic improvement you have mentioned. So name two condition which involves the upper airway, which can present like a recurrent airway obstruction like pathology. Simple. The upper airway. Could it be a laryngomalacia?
Yes, sir.
Why, sir?
Sir, laryngomalacia, they might present from birth, like stridor might be there from since birth, sir. Then.
So I'm giving a clue that means it is not laryngomalacia.
Sure.
Laryngeal involvement. There are certain conditions. Two important conditions I told you. You heard of recurrent respiratory papillomatosis?
It's a laryngeal papillomatosis.
That can present like similar to this condition. The child can have a recurrent bouts of cough. Okay. Suddenly they can go for apnea, lethargy. Because the partial obstruction, when there is any viral inflammation can precipitate this illness. Okay. That's you should keep in mind. Another thing is laryngeal hemangiomas. Okay, obstruction. So laryngeal obstruction I wanted to convey. Is it not subglottic hemangioma? No, Dr. Srinivas? Yeah.
Yes, sir.
And of course, pertaining to your case, GRD, GERD also has to be kept in mind. These are the three important conditions.
Spasmodic laryngitis also.
Yeah. Yes, sir. Yes, sir. Yeah. So that it will be, to dissect it out, it will be easy for you. So you should not just take it for granted. The child has a cough, cold, and nebulization is given no dramatic improvement. So why the child is not improved? What is the reason? Okay. So this is a significant past history you have to keep in mind. Okay.
In that connection, I like to emphasize, nebulization seems to be a panacea for anything concerned respiratory, without any reference whether it's going to help or not. So when patient gives a history, you have to dissect that history. Why was the nebulization done? What happened and things. Of course, you have brought it out. That did not make any dramatic. But many patients will tell you, I got a nebulization done. It should not mislead you on a different route. That's the only thing that's important for you to remember. Okay.
Got it? No, yeah. So
Yes, sir. Yes, sir.
Here, upper airway pathology, what I told, why you give an ablation, it won't help, is it not? Bronchodilation, unless there is a wheezy bronchitis. Okay.
Here they are given 2 times nebulization, no? So
yes, sir.
And with a background of cough and cold. So
yes,
can
sir.
it be can it be asthma in this case? Is it asthma?
Sir, asthma, sir, they have no dramatic improvement. What nebulization they have given, we don't know, sir. But if they have given like a beta agonist, there might be a response to that, sir.
Okay, one is response. What are other symptoms which suggest you make you suggest you of you think of the asthma?
Sir, history of history of atopy in the family, someone having like a history of allergies and
what's the symptoms in the child?
Sir, symptoms the child will have every seasonal they might have, sir, but in this child it is 1 year child, we can't say seasonal, sir. In any exposure to cold, the child might have symptoms cough and cold, sir, and change in water also can cause cough and cold, sir.
Specific, which are the symptoms will mainly suggest you of the asthma?
Sir, cough, cold and wheezing, sir. Wheeze.
Okay, cough, cold,
cold and wheezing.
More of the nighttime cough.
Nighttime cough, sir. Nighttime.
Dry cough. Nighttime cough. And then response to the your
nebulization.
Beta 2 agonist. So like these are the like features, and like which are the points against the asthma?
Against the asthma, like one there is a cough and cold, and like the cough is not like it is not persistent, like not more during night time, sir. According to history, and atopy history also is not there, sir. Then
yeah, I think we'll proceed a little because we are going a little.
Yes, sir. Yes. Yeah.
Okay, sir.
Point this one is, of course, this age group, this combination of cough, cold as a manifestation of allergy is not a common manifestation. Maybe a slightly older age group, 6 years, 8 years, can be more. Okay, so we go to the next slide.
Antenatal history, booked case at Hoskote Government Hospital. It was a twin gestation, spontaneous conception, no history of fever with rash or radiation exposure or lymphadenopathy. The mother diagnosed to have hypothyroidism at 5th month and started on medication. Weight gain during pregnancy was 13 kgs, and all scans during antenatal period was normal, sir.
Yeah, go ahead.
Pertaining to this case, what important antenatal history will be useful?
Sir?
Pertaining to your case, what important antenatal history will be useful? As we discussed initially, like Dr. Ravichandran sir has given you what are the causes, predisposing factor of aspiration. If you keep that in mind, so antenatal
scans, any abnormality showing any abnormalities, antenatal scan showing any abnormalities.
Okay,
be specific. Yeah.
I'll give you one clue. One condition associated with polyhydramnios.
Very good. Yes, sir.
Another condition associated with oligohydramnios.
Sir, trachea is a fistula, sir, in polyhydramnios, sir.
No. Sir is asking what antenatal history you will take for the polyhydramnios.
I'm just, since Dr. Prahlad asked, if the child had polyhydramnios, what will you think of for the risk for aspiration?
That's all. Simple, yeah.
Or
okay.
If the child has oligohydramnios, what is the chance of the child to have a respiratory abnormality?
Right, yeah.
Sir, polyhydramnios, they might have a history of like upper GI trichoesophageal fistula or esophageal atresia might be there, sir, in polyhydramnios history. And in case of oligohydramnios, because of less liquor, child may have aspirated meconium, and this will cause meconium aspiration. Child may have.
Don't go away. You answer to the answer to the point. See, excessive commitment is dangerous.
We have some answers in the chat box, sir. Decreased fetal movements like
good.
Decreased fetal.
Oligohydramnios with Potter sequence.
Yes.
Very good. Yeah, that's also important.
So what is it? Why is it that amniotic fluid important for lung growth? That you should tell, no?
Nice.
Okay.
Yes,
So decrease amount of fluid, decrease aspiration.
Okay.
Yeah, go next.
Good, Dr. Divya. Yes. Okay.
Birth and postnatal history. It was a term baby, twin one, female, delivered normal vaginal delivery with birth weight of 2.1 kg, said to have cried immediately after birth. No history of NICU admission, and early and late neonatal periods were uneventful.
Yeah. Next.
Immunization history. Child is immunized up to date according to national immunization schedule. BCG scar was present.
Yeah, good.
Yeah.
Good.
With this history, sorry, just go back.
Go back.
With this history, what is the child prevented against? Which other respiratory illnesses it is prevented against?
Sir, BC, like tuberculosis, sir, one BCG, sir. Second, Pentavac contains diphtheria, sir. Then pertussis. Then one more like H influenza, Haemophilus influenza, which can prevent the respiratory illness, sir. And fourth is MR vaccine, sir. MR vaccine, like measles, can precipitate to develop pneumonia. Can cause pneumonia, sir.
Post-measles.
The missing joker of the pack in this.
Which is
instituted.
Somebody, Prajwala, is answering.
Pneumococcal vaccine is missing, sir.
So now we have got a bouquet of vaccines to prevent all these childhood illnesses. That's what is important.
Okay, sir.
And COVID vaccine also issued. Not for 1 year old, not for 1 year old child. Okay. Further, any older child it comes.
Okay.
COVID pneumonias.
Okay, COVID.
In the background of pandemic. That should not be forgotten. Okay.
If the child is predisposed, influenza vaccine.
Influenza vaccines.
If they're affordable, they can take that influenza.
Developmental history. All developmental domains achieved appropriate for the age.
Okay.
So developmental history also very important pertaining to this case, especially the motor and mental. Okay.
Okay.
In detail, you have to take. Okay.
Okay. Next.
Dietary history. Child was exclusively breastfed till 6 months of age. Complementary feeding was started from the 6 month of age in the form of ragi sari, and breastfeeding is still continued. History of bottle feeding since 6 months of age, sir. And calorie requirement is 900 kilocalories. Consumed was 550 kilocalories. Deficit by 350 kilocalories. That is 38%, and protein is adequate.
Okay, we'll have its impact on the growth of the baby now?
Yes, sir. They can have, sir.
We will talk about it when we come to that. Yeah.
Anthropometry.
Okay.
Next.
This was a second born child of non-consanguineously married couple. The history of similar illness was there in the other twin. However, the twin was active and feeding well, sir. The distress was less. The child had only tachypnea, and it resolved with nebulizations and with O2 support, sir.
No, did it resolve all this history, that resolution and things occur by the time the child presented to us, or you're talking?
No, sir. No, sir. No, sir.
So the other child also had a similar illness.
Yes, sir.
So what is your impression as a result of it?
Sir, this is a viral illness, sir. That other family member also has a similar illness. Started with as a viral illness, sir.
Okay, cohorting of illnesses more common with
viral infection, sir.
Okay, good.
Yeah, instead of telling similar illness, otherwise it will take you to that also child has similar. Only thing, cough. Yeah, child had cough, like prodromal symptoms of viral infection you have to give. Otherwise, both are.
We'll go to similar.
Yeah. One more important thing for the postgraduates, you have to pedigree chart should be at least 2 or 3 generation you have to put it. Okay.
3 generation.
3 generation. Okay. Not a single one is not acceptable.
Okay.
Yeah. Okay.
Socioeconomic history, number of members in the family 5, father was a driver by occupation, income was 15,000, socioeconomic score of 14. They belong to lower middle class according to modified Kupuswamy classification.
Yeah, now tell us what you got the whole history now. Right? Everything is with you. With what presumptive diagnosis you're going to approach the child?
Child presented with cough, cold, and hurried breathing, chest indrawing, and vomiting, sir. The most, based on decreased activity, based on the history and past history, could it be a lower respiratory tract infection, sir? Based on the history, sir.
Justify it.
Sir, child had a viral illness. Which has caused hurried breathing and chest indrawing following the episodes of vomiting.
Pattern of viral illnesses to progress in a 24-hour time frame. 24-hour time frame, the whole thing has happened. Is it a normal?
No, sir. Not a normal pattern.
So I'll keep it more down, no?
Yes, sir.
Okay, rapid progression is there, no?
Rapid progression, sir.
So what other?
What are the 1 or 2 conditions? Tell within 24 hours, rapidly progressive disorders of the respiratory problem. Simple.
One could be hyperreactive airway disease, sir. Rapidly progression within 24 hours could be there. Then next one is foreign body, sir. Foreign body also can progress rapidly, sir. And the third, even severe pneumonia can also present rapidly progress. In case of bacterial pneumonia, can progress to rapidly. And fourth one is any like anaphylaxis, angioedema also can.
Don't bring everything into a box. Simple, make it simple. Yeah. First thing is you should bring it out whether it is not an infection.
Not an infection, sir.
Okay. Second thing is not an infection. What other causes? Could it be an aspiration pneumonia?
Aspiration pneumonia, sir. Second, foreign body. Third could be the hyperactive airway disease, sir.
Yeah, like that you should proceed. Okay.
Anything else?
Severe bronchiolitis also can have a similar.
Bronchiolitis, do they come with a prodroma or they come straight away as a bronchiolitis like that?
And straight away land up for ventilation.
No, sir.
Any other? Think beyond. Think beyond infection affecting the lung. Child going into acute respiratory failure for water etiology. I see Jeffrey saying it is
MISC.
Multi-system syndromes. Okay, it can be. But what you have to understand is ARDS is not only as a result of infection. The etiology of ARDS could be very. It could be.
IEM. Somebody's answering as IEMs.
Okay, toxins. And that's what Dr. Ravichandran. Toxin. Suppose that mother is given oil, castor oil, or kerosene.
Chemical pneumonitis.
So like that.
So the etiology of ARDS could be much beyond the infections. You have to know that the etiologies are plenty. So I would think about rapidly progressive. Of course, you have already highlighted a commonness of occurrence of in terms of aspiration. You have given in terms of foreign body, in terms of ARDS, in terms of hyperactive reactive airway disease. Okay. Now let's examine the child and see where we land up.
So for the sake of all the postgraduates, no, we are on the order of preference. We kept these 3 and 4 condition in mind, and we are progressing to examine the child for the evidence for this 3 or 4 condition. Okay, Shrishal, you got the point, no?
Yes, sir. Yes, sir.
Yeah, number 1, evidence for aspiration.
Aspiration.
Number
2, foreign body. Number 3, hyperreactive airway disease.
Yeah. Number 4, the predisposing
Factor
factor for
factors.
this. Okay, so these things has to be kept in mind and proceed. Go ahead. On the severity and complication of the illness.
Yeah, we have fully finished this. Go to the next slide.
On examination, child was sick looking and drowsy. Temperature was 97.8. Heart rate was 156 beats per minute. Respiratory rate was 72 cycles per minute with suprasternal retractions, subcostal retraction, and intercostal retraction. Saturation under room air was 78%. With O2 support, it was 82 to 84%. Peripheral pulses were well felt with cold peripheries. Capillary refilling time was less than 3 seconds, and blood pressure was 86/50 millimeter of mercury.
Okay, you can ask somebody in the panel participants, how to read these vitals in the light of this history? Prajwala? Divya? Nobody there, or they're just observing quietly?
Srishal, when the child comes to you in a ER, you have to do triaging, is it not?
Yes, sir.
That you have to
Primary.
put it.
Sir, primary assessment triangle and.
Yeah, you should put it in the triangle.
Okay.
Here, we just put it as a vital. That's what I told. He put it.
Yeah. Okay. So Prajwala is telling respiratory failure. Oh, okay. Respiratory distress or respiratory failure?
Distress, sir.
Why not failure?
Yeah. Okay. So you should know what are the signs of respiratory distress. What are the signs of respiratory failure? Shrishal, quickly.
Sir.
First, tell me the signs of respiratory distress. Then we'll
sir, tachypnea, tachycardia with retraction, suprasternal, subcostal, and intercostal retraction, and a saturation also under room air is 78, sir, and capillary refilling time is less than 3 seconds, sir. This it is suggestive of respiratory distress, sir. And
don't combine respiratory distress and failure. You should be very specific. What are the signs of respiratory? You are combining when the CFT is less than 3 seconds, cold periphery, oxygen saturation going less than 70, then it will going for respiratory failure. Don't combine. I'm asking you for the sake of your postgraduates. You should be clearly say these are the signs of respiratory distress.
Tachypnea, retraction, tachypnea and retraction, sir, and saturation. If it's maintaining 90 more than 85, then is signs of respiratory distress, sir. And capillary refilling time also is less than 3 seconds.
So what is it? Why are you hopping on the capillary refill time? This one. Can you have the capillary refill time coming down in an acute respiratory condition?
No, sir. No, sir.
Those conditions which can cause a capillary refill time without obvious cardiac lesion. See, this is going to, this is how you
commit yourself. Then that will tell you are not worked in an ICU. That's what picture they will give you. Is it not? You are not seeing a case in an ICU. That sorry figure you should not bring it. Shrishal, okay?
Okay.
See, Jeffrey's answered rightly. So you should give a correct picture. Yes, tachypnea, suprasternal, subcostal retraction, saturation not maintaining room air, but with oxygen support maintenance, the respiratory distress. So beyond that, what are the respiratory failure? Means the child is poor feeding, lethargy, drowsy, you are telling, see, drowsiness. Is it not? Even bradypnea, bradycardia, child, instead of tachypnea, child will go for shallow breathing, apnea. Is it not? That's all impending respiratory failure. And saturation is not maintaining. Of course, other added points to be given here. Child may be looking blue, cyanosed.
Cyanosed.
Is it not? Those are all respiratory failure, of course, supported by ABG. Is it not? So you should
Yes,
have
sir.
a clear-cut impression of respiratory distress and respiratory failure. No, Dr. Srinivas, okay, no?
Sir, yes, sir.
Yeah.
Just I'm checking the chat, sir.
Yeah.
Okay, go ahead, next.
Go ahead. So impression you didn't give, sir, with this. With this vitals, you should give the impression. No?
Child
Because based on the vital, we have to act immediately.
Yes, sir. Child is in respiratory failure, sir. With oxygen also, saturation is not improving. Tachypnea is there, tachycardia is there, and
respiratory failure.
And
but
child is sick looking and drowsy.
See here, what about heart rate? Peripheral pulses, cold peripheries you have seen, and CFT less than 3 seconds indicate what? Less than 3 seconds you have put CFT prolonged, normal.
Perfusion is normal or not?
Sir, perfusion is normal, sir.
Yes, BPS normal.
Normal, sir.
So, but how do you explain the cold periphery?
Due to the exposure,
yeah, see, you should be very careful, because whether child is in shock or not, you have to mention. So one of the important points is
earlier sign.
Cold periphery.
Yes.
Okay.
It should be very
environmental can be because of the body. Okay. So based on this, we have got two problems here. That is, one is the child is a respiratory failure. Okay, that is, it requires immediate attention. You can't wait for it. The other, of course, is telling you it has got a respiratory distress also. Now, from this type of what you have seen, there's a tachypnea, there's a lot of retractions, all. Can you know what is which is the area of the lung respiratory system?
Respiratory system involved, yeah.
Based on this, sir, parenchymal involvement is more, sir, lung parenchymal involvement, because subcostal retractions are there and intercostal retractions are there, sir. Based on that, parenchymal involvement is there, sir.
Okay. Anything else?
What about suprasternal retractions are there, no?
Suprasternal, like upper airway obstruction, could it be there, sir? Upper airway obstruction might be there also, sir, along with that.
Okay, so when you got retractions, see, subcostal, intercostal, or suprasternal, it is gradually progressive. There are to get in air into the lungs. Okay, so you know the level of obstruction is not only, it may be a parenchymal, but maybe involving the airways also, because it's trying to overcome whatever resistance is there. Okay, so what are the other indirect correlates of these retractions in the periphery? You understood my question?
Yes, sir. Yes, sir.
From the test you are seeing, there are a few other correlates also. We know straight away this child is in hypoxemia. What are those correlates?
Child will be irritable.
Irritability is only start of the scale. This child is drowsy, you have told, it's irritability scale. It's gone beyond. Anything else? Because these are observational. You don't have to touch the patient to see this.
What would be the color of the patient?
Cynos, like a bluish color. Cyanosis might be there, sir.
Okay, you can have cyanosis. Anything else?
No.
How will be the head?
Head bobbing. Head bobbing will be there, sir. Head bobbing will be there, sir.
When you see a child with head bobbing, you don't
head bobbing.
You know straight away this child has got distress.
Distress.
One is the head bobbing. Second? I think you are going to show it in the respiratory system, but you can think about it here also. What happens to the nose?
Nose.
Anything on the nose you can make out that this child is in distress, it is trying to get in, maximize the air.
Nasal flaring will be there, sir, and nasal flaring will be there, sir.
Peripheral evidence of hypoxemia.
Nasal flaring.
Okay. Yeah, go ahead next.
Anthropometry.
Yeah.
I think No, so I think internet connection something is stuck.
Weight for length is -2 to -3 standard deviation. We are moderately wasting. Head circumference is 42.5 centimeter. Expected is 44.9. It is -1 to -2 standard deviation. Mid-arm circumference is 12.5 centimeter.
Since it's not a nutrition case, one single question I'm going to ask. This child was born with a weight of 2.1. I said this child is growing small.
Small for gestation.
He was born 2.1. 6.1 is reached.
Normal.
Is reached, which we expect of many children. What is the one which is telling you, no, he's not even getting his nutrition proper?
Mid-arms length, sir. Length, one length and mid-arm circumference also length and
this you have put this, you are only not interpreting.
Divya has answered.
Weight for height, weight for length is
it's also less.
Weight for length is less, sir. Weight for length is less, sir.
So you shouldn't this child though small. Normal. Not adequate weight for his length. Okay. Yeah, go ahead.
Head-to-toe examination, head, anterior and posterior frontally closed, eyes were normal, nose discharge was present, oral cavity normal, pallor was noticed, no clubbing, no cyanosis, no edema, no lymphadenopathy, skin, no rashes, no petechia, no purpura, back and spine normal, genitalia normal, female type.
Any questions for him?
Anything in the examination? Any positive things?
No, sir. A nasal flaring was there, sir. Other than that.
So you put there, no, nose discharge plus, plus. Okay. Go to the next slide.
Respiratory system examination, inspection. Nose discharge was present with nasal flaring. Chest, left side of the chest appears to be more prominent when compared to right side with subcostal, suprasternal, subcostal, intercostal retractions. Trachea could not be assessed. Apical impulse not visible. No visible palpation seen. No scars or no dilated veins.
Okay. So, interpret this one finding for us.
Child is having respiratory distress with nasal flaring, sir, and subcostal, intercostal, and intercostal retraction, and reduce left side. According left side chest appears to be more prominent. It looks like hyperinflation, sir, and hyperinflated, sir. And apical impulse is not visible, sir, and trachea could not assist because the child was not cooperative. And
so, what is your impression? What were you expecting? What are you seeing? You got a child who has come with a respiratory distress, who has become hypoxemic. On inspection, you find these findings.
You find child is having retractions also, and with all these things, what is your impression? With the inspector.
Chest, left side of the chest more appears to be more hyperinflated.
Okay, left side of the chest is hyperinflated and then it is more prominent. Then
what prominent?
What else he has? Retractions is there.
Retractions is there.
Suppose you have no asymmetry of the chest. Both the chest was looking normal with only retractions, and vis-a-vis this where you find some sort of asymmetry. What comes into your mind? That's what
Sir, there might be a collapse.
There in the patient. No, we can't go. All patients can't go directly to the X-ray suite and get the X-rays and then come and say, "Oh, I got this or that."
There might be a collapse on other side of the chest, sir. Could be, sir. Then
left side of the chest is more prominent.
Yes, sir.
With it's hyperinflated, right?
Yes, sir.
You're thinking pathology is on one side.
Left side pathology is there.
No, if it would have been on the both the side, you will think of what you will think. If there is no asymmetry, what do you think? If child is having respiratory distress, no asymmetry. So probably
Probably
both
both the lungs have could it be like a hyper reactive airway disease, ma'am? Bilateral there will be a hyperinflation.
No. You're talking about etiology. So pathology wise, there is involvement of both the lungs. If you don't find any asymmetry, if you find a asymmetry, probably there could be a unilateral pathology. Pathology might be on the one side of the lung. One lung.
Okay, now I'll say left side is normal, right side is abnormal. How do you differentiate this on inspection alone?
Right side based on the chest movement, sir, and chest movements, sir. Chest movements, sir. Chest movements, chest movements, sir.
Whichever has got less chest movement.
Chest movements.
This is the classical teaching from MBBS upwards. We say which side moves less is problem side. Okay.
Okay.
Okay. Anybody else any interjections in this slide? Panelists?
Prahlad sir, anything else, sir? Okay, I think you can move it, sir. Next slide, sir.
Palpation, all inspection findings are confirmed. Trachea shifted to the right side, and apex beat is in the left fourth intercostal space, just medial to mid-clavicular line. Chest movements are reduced on the left side when compared to right.
So what is the refinement of your examination findings?
Sir, trachea shifted towards other right side, indicative there might be a pathology on the right side. Sir, could it be a collapse or a fibrosis on the right side?
In the previous dialogue, we had told you how to identify which side could be more problematic. In this, what has happened on the left side?
Left side, there is hyperinflation, which could have caused the shift of the trachea, or any air or any fluid which has called.
Left side movement more or less?
Less, sir.
So if movement is less, I told you in the previous, whichever side movement is less is
pathology, sir.
On both the sides, but this has got more pathology. That's why the whole picture is, after all, it is a chamber. Now the pathology is more, it will push others. It's like a crowded bus. Fat man gets in, others, even if the other fellow, one more thinner fellow is there, he gets pushed to another corner. That's all. That's the way it is.
Yes.
So you think the pathology is on the left side more than the
right side, sir.
Okay. Next.
Percussion on the right side, impaired, not heard on the supraclavicular area, infraclavicular area, and the rest of the fields were like resonant node was heard. Liver dullness was noted from the fifth intercostal space, left fifth intercostal space, right fifth intercostal space, and left side hyperresonant node in the mammillary or inframammillary area, and the rest of the area where resonant node was heard.
Okay. What is the caveat when you do a percussion in this young babies, 1 year child or a 6-month child? What are the points you should remember? See, I'm not going to reiterate all the principles of percussion, okay? But when you percuss in this young children, what are the points you would pay attention to? Of course, they say percussion may not have great validity in children, but still, it's a valid clinical finding, with a clinical method we can adopt. So what is the precautions you should take? That's all. Anybody in the chat box? I can't see.
No, sir.
See, it's important that when we percuss, we do not use heavy strokes because of small chest.
It's small chest.
Number one. Number two, classically we have been taught to percuss with 3 fingers, middle finger, the pleximeter, and 2 fingers to support and things like that. You cannot do it because the chest is still more small. So you can do what is called as a single finger percussion. Number two, the percussion should be gentle because heavier percussion will cause the whole chest to vibrate. So you may not get the findings which you are looking for. Okay.
Okay, sir.
Whenever you percuss young child, infant, young children who have got hardly any muscle mass, your percussion should be gentle. You can use a single finger as a pleximeter, and gentle percussion will get you better results than heavier percussion. If you remember this, you will get good results. Okay.
Okay, sir.
So what is the interpretation of what you got here?
Impaired node on the right side of the chest on the supraclavicular or infraclavicular. There might be there might be a consolidation or a collapse on the right side of the lungs, and left side hyper resonant node in the mammary and inframammary area might be some amount of air trapping, or could be a
is a pneumothorax?
Pneumothorax could be, sir. Hyper resonant node in the mammary inframammary area might be pneumothorax, sir.
What additional percussion you can do to find out if it is pneumothorax or it is a hyperinflated lung?
Coin test.
You done the coin test, no?
Coin test, sir.
Okay, did you do it?
Coin
No,
test.
sir.
No,
Mainly for
transillumination.
In the small chest, you can do a transillumination with a
Transillumination also.
Transillumination.
Okay. Otherwise, it will misguide you, and child will be in severe respiratory distress.
And it can be immediately attended to. Diagnosis of pneumothorax at the bedside is very, very important. Okay.
Okay.
In the right side, you said impaired node and supraclavicular and infraclavicular area, no? Which part of the lung is involved here?
Sir, upper lobe of the right upper lobe is involved, sir. Supraclavicular and infraclavicular. Upper and upper lobes.
Left side?
Left side, it is lower zone of upper lobe and lower lobe, both are involved. Lower zone of upper lobe is involved, sir.
Lower zone of upper lobe means what?
Left lobe.
You are having microscopic examination finding.
Sir, upper lobe is involved, sir. In left side.
Be specific whether upper lobe is involved or what.
Zone you use in the X-rays, not in the clinical.
Okay.
Okay. So clinical examination lobes.
Detail, I just told you the limitations of percussion in a pediatric chest. More limitations.
Okay.
Not localized with some. Yes, I know it may be affecting those areas of the lung which are deep under that area we are percussing. I will not be able to say very. Unlike like in a bigger child or a adolescent. Okay.
Okay, sir.
Yeah. Go ahead.
Okay, next.
Auscultation, diminished breath sounds were heard on the left mammary and inframammary area and right infraclavicular area. Rest of the lung feeds, normal vesicular breath sounds were heard. Bilateral rhonchi and crepitations were heard, sir, in all the areas.
So
all the areas, bilateral rhonchi, yeah. How it can be? You said rest of the lung feels a normal vesicular breath sounds. Okay.
Yes.
Yeah. Crepitations all over the lung fields.
Yes.
Is it
that is like
right on your part to say crepitations all over the lung fields means what is your impression?
Crepitations or rhonchi you're telling? Like both the crepitations and rhonchi are there on all the lung fields?
Rhonchi were there all in the lung. Crepitations in the infra-axillary areas of bilateral infra-axillary area and axillary areas, sir.
I got to ask one question. What are the mimics of crepitations in a pediatric chest? Because every sound that you hear is not a crep.
Yes, sir.
So what are the mimics?
Simple question, no? Which looks not a crep, whether it could be a conducted sound.
Conducted sound.
Conducted
simple
sound.
way you should go always.
After all, it's a very small volume between the chest and the abdomen. You can hear multiple things. It could be mimic A simple thing like you are not applying your diaphragm very close. One, it could be as a result of a subcutaneous emphysema. It could be an abdominal sound transmitted. It could be a pleural rub. See, there's so many things. Most importantly, the pediatric vesicular breath sound itself is a large. We call it as a puerile breathing, a harsh vesicular. That itself may convey as if it is a very fine crepe. So one should not make an impression directly out of that this crepe is here or that crepe is there in that area. Okay.
Okay, sir.
Not be very productive. What is important, which a point I would like to highlight is your auscultation findings are not very important vis-a-vis your other findings which you come to. They're telling you the mechanics of the lung. They're telling you the mechanics of the underlying pathology. They're also telling you about what is its function, whether it's able to function. Okay. Next.
Systemic examination, cardiovascular system. There was a tachycardia, normal heart sounds were heard, no murmur, no gallop rhythm. CNS, central nervous system, the child was drowsy and pupil were bilaterally equally reactive. A tone was reduced in all 4 limbs. Per abdomen, soft, non-tender. Liver and spleen were just palpable, sir.
Cardiovascular system, is there any shift of apical impulse you told?
Sir,
the palpation is called, no? Something.
Sir, left fourth intercostal.
So is it normally located or is there any shift?
Shift, sir. Shift of the apical impulse is there, sir.
Where? Opposite side, same side, or it is?
Sir, opposite side, sir. Opposite side, right side, sir.
Because trachea is shifted to the right, so it takes you whether the apical impulse also shifted to the right. Oh, mediastinal shift. That's what you wanted to know in this child. Okay.
Okay, sir.
Similarly, in percussion, is there any obliteration of cardiac dullness? Because the left side, hyperresonant note in the mammary area is written, no?
Yes.
Cardiac dullness also, is it obliterated?
Yes, sir. Yes.
Okay. Right, go ahead, yeah.
Summary, sir. 1-year-old child, a second born to non-consanguineous marriage, developmentally normal, fully immunized with dietary.
Your diagnosis. I think we have all heard all these findings.
Yeah. With the history and with the examination finding, what is your simple diagnosis?
Sir, based on history and examination finding, there could be the first, the provisional diagnosis could be aspiration pneumonia, sir. As a history of consumption of ragi.
We'll go, see, we'll examine the child also.
Okay, sir.
See, which are the examination includes the anatomical
and
the etiology.
Anatomical etiology. Oh, in the order.
Anatomically,
is a lower respiratory tract infection.
Pathology or left side pathology?
Sir, anatomically, there is a pathology in the left side also, sir, and it's right side also, sir.
What is that? What is the pathology? What is it?
Right side, there might be a collapse or a consolidation, sir. Right side, sir, because impaired note was there on the right supraclavicular and the suprascapular area, and breath sounds were also reduced, sir, on those areas. And left side, there is a hyperresonant node on the mammary and inframammary areas, sir, with diminished breath sound in the corresponding areas, sir.
So, what is your anatomical diagnosis?
Primary diagnosis, like collapse or a consolidation of the right upper lobe, or emphysema or a pneumothorax of the left.
What is the evidence of collapse of right upper lobe?
Simple, yeah.
Sir, like pull of the trachea, sir, like towards the one side, and reduce the breath sounds on the side.
If there's a pull of the trachea to one side,
yes, sir.
Does it of a collapse only? But there's many other findings which are not going with it. He's also got shift of the apical impulse.
Yes, sir.
When a collapse of a single upper lobe cause such a mediastinal shift.
Okay, sir.
Can it?
No, sir. No, sir.
So I will hold that card as a little lower.
Later, lower down, sir. Left side, there might be a new emphysema or a pneumothorax of the left lungs, sir.
Emphysema. Why emphysema?
Emphysema. Because of
left lung again anatomically.
Anatomy, like any obstruction which is causing obstruction and causing air trapping and leading to emphysema, bulla kind of thing. Emphysema kind of.
Okay, you may hyperinflation of the left lung, you mean? Okay.
Yes.
Okay, but which is more likely if I give you a choice to choose between pneumothorax and air trapping of the left lung? I will not call emphysema. When we say emphysema, it will lead to breakdown of alveolar walls.
Walls.
Trapping of the left side. Which would you like to choose?
Sir, air trapping on the left side.
Yeah, whether it's air trapping on the left side or pneumothorax. Simple question. What are the pointers to say pneumothorax? You can tell me. Otherwise,
Sir,
clinical examination. These are the pointers to pneumothorax.
Sir, in the pneumothorax, there will be a absent breath sounds will be there, sir, and the points favoring this is there is a hyperinflation, sir, and on the examination also there is a hyper resonant node in the mammillary and inframammillary area, sir. Then
which is common here?
Yeah, air trapping is more common, sir, when compared to pneumothorax. Partial obstruction causing
You mean to say pneumothorax is rarer than emphysema? The commonest thing we have a respiratory distress, either it's in the newborn or a later age group. Whenever you got a respiratory distress, we always suspect a
pneumothorax.
That's a more common pathology. Number one. Number two, if it's an emphysema, would you expect so much of a mediastinal shift? Like
no, sir.
So many air trapping.
No, sir. No, sir. No, sir.
So there is definitely a
push
of the left side. So I would think of a pressure situation. Pressure is more.
Okay.
So now if you've got a pneumothorax on the left side, what could be the etiology next?
Etiology, could it be aspiration, sir, which and a particle, any particle which is the child has taken, which has caused the obstruction to the main bronchus, causing pneumothorax, sir?
No, obstruction to the main bronchus will cause collapse.
Collapse will cause
occlusion. Partial will cause hyperinflation. Is it not?
Yes, sir.
Then if it is causing pneumothorax, so you should specify, I am dealing with what type of foreign body, or the child struggled to remove the foreign body by vigorous cough.
Yes,
is it not?
Yes, sir.
Is it a traumatic foreign body?
I'm just asking,
should analyze.
What are the etiologies of a pneumothorax in a 1-year-old child who comes with a sudden onset of a bouty cough and he gets into distress?
Sudden onset.
The congenital can manifest at the later age group?
Congenital manifestation, sir.
Very common in the left upper lobe.
Left upper lobe. Lower lobe sternum, sir.
Somebody is mentioning subpleural parenchymal.
Pleural, subpleural cyst.
No, yeah.
Somebody is mentioning.
Because your diagnosis is there in the line, but what is that? It's called. What is it? Congenital.
Like this.
Lobar emphysema.
Congenital lobar emphysema. He can have a lobar
emphysema.
As a violent bout of cough and he ruptures the bullae.
Okay.
Okay. Or second cause. Can you have such a scenario in a case of asthma?
Shift of mediastinum, their child might not have such shift of mediastinum. Hyperinflation will be there.
No. I understand the question.
No.
Causes of pneumothorax he is asking.
That is asking cause of pneumothorax.
That's it.
When you have a pneumothorax, you know the cause.
Common causes, rare causes. No.
Common cause.
Okay, we'll be running short of time. You see, when you have a pneumothorax, there's some air connection
Coming in.
Commons could be lobar emphysema. It could be a cause of, in an acute presentation of acute severe asthma, you can have a pneumothorax. You can have a pneumothorax because of an infective bullae opening up into the pleura. Then, of course, the hydrogenic, we keep doing it in the NICU quite often. We ventilate with abnormal pressures, we create a pneumothorax. These are the common conditions which can cause pneumothorax in our
Staphylococcal pneumonias. Is it?
So you should know this. Common cause of pneumothorax. Okay.
Doctor says, right. Go ahead. Yeah.
How do you proceed?
Initially, child will secure a airway breathing circulation, sir. If airway is stable, child is will give initially with O2 support, sir. With the O2 support and try to stabilize the airway.
You are going to take care of the oxygenation.
Airway oxygenation, sir.
Okay.
Even with that, the child is not able to improve the saturation and distress is like similar. Then we'll go to other ventilator supports like NIV or a HFNC or a CPAP.
I told you, no, you'll take care of the oxygenation, maybe by oxygen or CPAP, HFNC, ventilation, whatever you're going to use.
Okay, sir.
Requirement of oxygenation. Okay, done. Next.
Next, fluid management, sir. IV fluid will start off with IV fluids and nebulization.
Okay, we'll go for the specific management of this.
Specific management. You like to get the diagnosis, no?
Your diagnosis, no? This is the.
What is your diagnosis? We only hypothesized. Where is the diagnosis? Would you like to go for any modalities, imaging?
Like chest X-ray will do, sir. Chest X-ray.
Next.
Show the read the chest X-ray. Yeah.
This is sir. It is it is a AP view chest X-ray, which is well exposed, sir. Bilateral. There is a left side hyperinflation is there with a patch of consolidation on the upper lobe of the left side, and right upper lobe there is a homogeneous opacity in the right upper lobe, sir.
Oh, where is the patch in the right upper lobe? It is not there. See, trachea. The trachea.
Where is the trachea?
See the trachea.
Trachea is
shifted to cardiac, mediastinum.
Trachea is shifted towards the right side, and the mediastinum is also shifted to right side, sir.
That's very important finding.
How are the ribs looking? They are looking.
Sir, hyperinflated, sir, widened, sir.
Widened, hyperlucent.
Hyperlucent and hyperwidened, sir.
Is it a pneumothorax now?
Now you tell whether it's a pneumothorax or a hyperinflation. Because you said, so I'm thinking of these two conditions. So X-ray will give you a clue whether I'm dealing with a pneumothorax or emphysema, what you said.
In pneumothorax, how the X-ray look?
Like more hyperlucent.
What about the lung?
Like a lung will be hyperlucent with absent bronchovascular markings, sir.
Now, what happens to the lung margin?
Important
Lung margin. What happens to lung margin?
That's a pointer, is it not? That's a pointer towards pneumothorax. See, same thing will be there in pneumothorax as well as the hypertension. That's what you are telling. But one important pointer, or Dr. Singh was clearly raised, which will give a that it is pneumothorax. If it is there, that means lung margins. What happens to the lung? Pneumothorax means collection of air in the pleura. Is it?
Pleural, subpleural.
So when there is a pleural cavity, collection of massive air, what is the underlying lung, Baba?
It's a balloon which is burst, no?
Yes, sir.
So what happens? Where it will burst and how it will burst? You can see the margins, is it?
Yes, sir.
Towards the hilum. That should be your answer.
Suppose it's a pneumothorax, what next? You can go to the next X-ray.
Sir, this was the second X-ray. After few hours of admission was taken. Sir.
What happened? There is some changes, no, compared to
last X-ray, sir. There is a consolidation or a collapse in the right upper lobe of the lung, and there is a hyperinflation on the left side with lower lobe pneumothorax, sir. Lower lobe.
Don't say lower lobe. Pneumothorax is in the cavity. I told you, no.
Cavities.
Collection of air in the pleural cavity. Don't bring lung here. Lung.
Okay, pleural cavities.
So what happened here? So the arrow pointing towards the pneumothorax.
Yes, sir. Pleural margins are visible, sir, in the left. There's an arrow which is pointing.
There's a needle.
No, sir.
What is the radiopaque shadow there?
It's an arrow, sir, which has pointed towards the subpleural.
Subpleural. You've got a pneumothorax here.
Pneumothorax, sir.
Okay, what did you do next?
We done we put a butterfly needle in a second intercostal space to see whether there is a bubbling or not with that, sir. And after that, we have inserted a ICD, sir, intercostal drainage tube in the fourth intercostal space and mid-axillary line, sir.
Okay.
Now, what happened? You should see, your putting is not an important thing. What happened immediately? What you observed?
Sir, there was a minimal bubbling when we put like butterfly needle in second intercostal. There was minimum bubbling, sir, in the second intercostal. Then later, even after that, saturation, it was not maintained. The child was intubated, sir. Later, after intubation, we put an intercostal drainage tube in the left fourth intercostal space. After that, there was persistent air column was noted, sir, in the ICD which we have put, sir.
Air bubbling, you have to say, okay.
Air bubbling goes.
Hissing noise, and it's a bubbling of the air. And with the bubbling of the air, child should show improvement.
There was an improvement in
distress should come down.
Saturation was improved, sir. Saturation was
That's the pointer, is it not?
Yes, sir.
Those are the things. Of course, if you do a repeat X-ray, that X-ray will be come back
normal. Sir.
So these are the evidence you should say, and ABG, of course.
Is there any evidence of tension pneumothorax? What are the clinical evidence of tension pneumothorax? Any this thing is there?
Clinical evidence.
Usually, what will indicate is having tension pneumothorax?
There is fullness of the chest, like intercostal space will be there.
That is in pneumothorax, in tension pneumothorax. In tension pneumothorax, usually there will be shift of the mediastinum away from the air leak. The gross shift will be there, and there may other than sometimes it may not be there. So in the even tension pneumothorax also because of the bilateral involvement if it is there. So then it is evidence of circulatory compromise if those things are there. Or when you put a needle, if the air gush, like a lot of air gush is there, high sound. If the sound indicate of the tension pneumothorax.
In a learning point for this one is whenever there is a pneumothorax in neonates or infants, the pneumothorax is not the problem. The collapse of the OSCE is a major problem. That's why we need to act immediately. Even with the suspicion, you can go ahead and put in the butterfly needle because these vessels collapse with the push. So it's very, very important to drain the pneumothorax at the earliest, not waiting for X-ray 2 hours or 3 hours and then do it immediately. Others, you'll have a collapsed child on your hand. So that's a learning point which I would like to emphasize in suspicion of pneumothorax. Okay. Go ahead next. We are running short of time.
In view of worsening hypoxia and poor juice, child was intubated mechanically ventilated on SIV mode with the saturation of 80 to 84. In view of not maintaining saturation with high parameters, there was reduced air entry on the left side, suspected pneumothorax, confirmed with repeat chest X-ray. Neoidal thoracostomy was done on the left second intercostal space. Minimum bubbling was noted. Following that, ICD was inserted in the left fourth intercostal space, and persistent 8 column was present, with which the saturation improved marginally.
Yeah, next.
This was an X-ray which was taken following intubation and ICD, sir.
Okay.
And this was an investigation which was done. HB was 10.2. Total counts they showed leukocytosis with a neutrophilic predominant. PC was 31.4 and platelet count was 3.14 lakh. Peripheral smear osmocytic normochromic anemia with electrolytes normal, and CRP was 1.6.
Okay.
Impression. What's your impression?
Sir, there is a anemia with leukocytosis, sir, with neutrophilic predominance, sir.
What's your impression?
There is a infection, sir.
Infection, where is the evidence?
CRP is
because you said
counts.
Leukocytosis is always infection, or is just an acute phase reactant?
It's an acute phase reactant, sir.
So we can't read too much out of it. Yeah.
Yes, sir. And bronchoscopy was done for foreign body suspicion in view of sudden deterioration. Non-bronchoscopy, the rice particle along with the mucus plug was obstructing the right and left main bronchus. On the removal of the same, the child was improved and was extubated after 2 days and put on a HFNC support for 2 days, and later was depronged to O2 support. Child required oxygen support for 10 days. At the time of discharge, the child was stable and off O2 support.
See, bronchoscopy was done in view of not sudden deterioration. Your
like
examination finding itself will say, is it not?
Yes, sir.
The child should have hyperinflation on one side. Why the child should have one side? That itself says whether there is an intraluminal or
extraluminal obstructions.
Is it not?
Yes, sir.
So do not wait for the child to suddenly deteriorate. That's a carry-home message. We knew of the history. In history only we dissected out. It doesn't look like an infection. It looks like a more of an aspiration. Well, is it not? In
yes,
that
sir.
itself, then on examination also, there is, of course, it should have been unilateral, but here bilateral finding, that also shows there could be an obstruction on the both the sides.
Both sides, sir.
Complete obstruction, other
one
side
side partial obstruction.
So if there is a partial or complete obstruction, you have to go ahead with the intraluminal obstruction. Bronchoscopy is the first investigation of choice. Is it not? So we should wait for the child to go for sudden deterioration. Got it?
Yes, sir.
Yeah.
Yes, sir.
Yes, I think we have come to the end of the case. Dr. Srinivas, would you discuss the OSCE before I do the conclusion?
Okay, sir. 1 minute, sir. Just 2 minutes. Just a battery low is coming, sir. Just 2 minutes. So the first OSCE. So anyone is the answer? Can I see in the chart box, sir? Like, can you go to the chart box?
User emphysema. First OSCE is emphysema. First green color is emphysema.
I think some of them have answered.
First.
Okay. So I think chart box, like I don't see any of these answers. So the first question of the in this what is the question? The first question was identify the study.
Picture in
so this is the picture is the spirometry of flow volume loop. There are different flow volume loops. Just to go back to the previous slide. Just to
yes, sir.
Just like in this. So whatever this the curve is a normal curve. So
no, green one.
The normal, the middle one is a normal curve, and the left side, whatever is there, this is the indicative of the obstructive disease.
Obstructive disease.
And this is the third one. This is the indicative of the restrictive lung diseases. This is the obstructive lung disease and restrictive lung disease. what happens is, even in the first blue color one, this loop, how it forms means there is a FE1 force expiratory volume of 1 second. So that will be drastically reduced in the obstructive diseases. That's why, so there will be a drastic reduction in the things, and there will be a concavity of the things. But there will be a vital capacity. A forced vital capacity is the one thing, total volume of the air which is expelled during the expiration. So that is the normal in case of obstructive diseases. Forced vital capacity will be normal, but the total lung capacity also increases, and then as well as the residual volume also increases. That's why the obstructive diseases, there will be a shift of the volume loop in the right side. So here you can see usually there will be a 6 liters of volume, but here the volume is increased. That's why there will be a shift in the left side. So that is in the obstructive diseases. So in case of a restrictive diseases, so there will be a residual volume as well as all the volumes, most of the volumes will get reduced. So the FEV1 as well as the forced vital capacity, both will be reduced. So FEV1 by FEVC, so both will be reduced, proportionally reduced. That's why there will be the shift to the right side. Okay, so this is the blue loop is indicative of the obstructive lung disease, and the orange loop will indicate of the restrictive lung disease. The example of the obstructive lung disease, all of you know, there is an asthma. So emphysema also are there, and then in the restrictive lung diseases, mainly the pulmonary fibrosis and interstitial pneumonias. So these things you can take, and in non-pulmonary causes also, neuromuscular disorders also you can say GB syndrome, all those interstitial disorders. Non-pulmonary causes also you can think of. This is regarding the first the OSCE. So go to the next slide. This is the second OSCE. Second OSCE, this is the X-ray picture. So clearly you can see here the heart margins are clearly visible. So the heart margins surrounding that there will be air. So the mediastinum air is there. So it is a pneumomediastinum. So almost extending into the neck. Okay, almost extending into the neck. So the most common cause of the conditions, this condition, pneumomediastinum in the older children and the teenagers, is the second question. So the most common cause of the pneumomediastinum in the older children is usually the asthma. So asthma is the most common cause in the older children and the teenagers. But in younger children, especially in the less than 7 years, lower respiratory tract infection also can cause this pneumomediastinum. So there are so many other causes pneumomediastinum will be there. So like there will be reported after the vomiting, severe vomiting, dental extraction, so adenotonsillectomies, then high flow nasal cannula therapy if you are giving. So there also you can see this pneumomediastinum. So the other two most the important complications is the third question. In these cases, the complications can be like the cardiovascular compromise can happen. That is the one more important. And another thing is that it can lead to the pneumothorax also. These are the two complications usually we will see in the pneumomediastinum cases. Okay, this is about the OSCE.
Thank you, Dr. Srinivas, for those two OSCEs. So this evening we discussed a common presentation in pediatrics, that is a child coming with an acute respiratory disease of short duration. Now, what will be the approach? Of course, when you have a situation like that, if the child has cough only with a respiratory distress and cough with fever with respiratory distress are two different cups of tea. Cough and fever with respiratory distress could be most often on the infective etiology, which comes into the ARI stream. We approach it like the ARI to see whether it's associated with increased work of breathing, decreased activity, decreased feeding, etc. But if it's not coming with those sort of, this one is just with a cough with a sudden onset of respiratory distress, we have to think about some compromise of the airway, the intraluminal or luminal or extraluminal compromise of the airway, and then our questioning pattern, etc., will be all dependent on the situational. What happened, may happen, the parents, we need to ask a more closer history. And of course, once we have a history that where we think that it could be most often in terms of frequency of occurrence, it could be a foreign body, then more common than aspiration, because out of the various studies done, aspiration in pediatric age grades is much less common than what is seen in the adult, unless the child has those predisposing conditions, either it's a neurological abnormality or a upper oropharyngeal abnormalities or esophageal abnormality. Otherwise, in a normal child who vomits, who has got his mental faculties alert, aspiration is a less commonly seen entity. Once we have this, then if it's a foreign body, then of course the approach remains whether the foreign body is stuck in the glottic opening or beyond. If the child has got a glottic opening, it goes through the basic life support or pediatric. We do not do a finger sweep. What is important is to do a chest back slap and chest thrust. That is taught in our PALS courses. That's what should be done. But if it's beyond the glottis, subglottic or beyond, of course, all this may not work very effectively. We may have to take the help of our colleagues from the ENT who will have to do either a rigid bronchoscopy if it's in the main bronchus. But if it's a smaller vegetal foreign body, which may be something in the form of this, like in this child, a rice particle or something, it can travel down the channel. So if it's going down the channel, of course, we may, though recommended is definitely the rigid bronchoscopy, but if it's gone to the second order bronchus or beyond, sometimes the fiber optic bronchoscopy also comes in very handy to remove such small foreign bodies. But most important in all of this is, regardless of the etiology, maintaining of oxygenation with the best available means, with keeping the metabolic rate as low as possible would be the target for us till we get more specific guided help to overcome this barrier of the airway. So with that, I'd like to conclude. Any questions from the audience, from the senior people on the from the other panelists? We'll answer them.
Thank you, sir. Thank you for that wonderful discussion, and thanks to all the panelists. A few other things that we have to keep in mind when you have a child with acute onset respiratory distress, in the absence of fever, is an acute lung bleed. These children can have pulmonary bleed, which can be spontaneous. That's one issue. I think there is a series of cases from Dr. Kabra from All India Institute, where the mother has fed the baby rice and dal. Some children have hypersensitivity to dal and they develop this distress and they go into interstitial lung disease. I think the best teaching point today we all learned was, if the event is around the time of feeding, then we will have to strongly suspect the possibility of a aspiration. Generally, people believe that aspiration is more common on the right side, but we now know that aspiration can be more common on the left side, which your case amply brought out. The postgraduate should remember that if there is a pneumothorax, then you should see the part of the collapsed lung. In the absence of that collapsed lung, you can't think of a pneumothorax. The other last possibility which can occur is a delayed diaphragmatic hernia. The child may be born normally, but the child can have a diaphragmatic hernia later on, more common in adolescents and younger children. With those few words, thanks to the moderator. You had promised us a respiratory case, but you gave us a very illustrative respiratory case, and thanks to all the three panelists and the presenter. I think he took most of the brunt, but we all felt that he did a real good job. Over to Suman.
Thank you very much, sir.
Thank you, sir. Thank you very much, sir.
Thank you, everyone. With this, we come to the end of an interesting evening, and this has been the 7th program of the year, that is with the coordination of IAP Karnataka as well as Bangalore Pediatric Society. I would like to thank Dr. Ravi Chandra, Principal of MV Jairam Medical College and Research Center, for bringing us such an interesting case and sparing his valuable time for us today evening. I would also like to thank the other experts of the team, Dr. Varsha, Dr. Srinivas, and Dr. Prahalad sir, who brought in several insights into this points and also pointed out many interesting points, which is a take-home point for every postgraduate, not just for exams, but also for every case which walks into the emergency. I would like to thank Dr. Srishail, who's taken in a lot of efforts in presenting this case and making it interesting, hoping that more and more postgraduates actually start answering live while the session is going on and not just answer in the chat box. So the whole idea of this presentation is everybody should actively take part and start answering by unmuting.
Yeah, this is meant for them, Dr. Suman. Yeah, this is mainly for the postgraduates.
Yes.
As you rightly said, they have to actively come and participate.
Yes. And I think Dr. Srishal that way had been pretty bold and he's been answering. But one thing which we have to probably always keep in mind is that take some time in answering, because if we blurt out sometimes, I think like the moderator and the experts have pointed out, sometimes that can work against us as well. So I think that has been one of the take-home points of today's discussion as well. I would like to thank IAP Karnataka President Dr. Rupa Ballad Madam, Dr. Manisha, IAP Karnataka Secretary. I would also like to thank Dr. G.V. Basavaraj, President of Bangalore Pediatric Society, Dr. Priya Shivalli, Secretary of Bangalore Pediatric Society. I would like to thank Dr. Nagbhushan, who has been the designer of this entire program and who's been actively motivating all of us to answer and even take part every time. And I'm sure all the stalwarts who are here also are really keen to see how the postgraduates are doing with every session. So I'd like to thank all the senior panelists who have joined in us with us today evening. I would like to thank the other PG program conveners, Dr. Raghunath, Dr. Madhu Pujar, Dr. Mahesh Kamte. Lastly, I would like to thank DIAP program technical coordinators, Hu and Joel, who have been helping us out with this program. Last but not the least, all the postgraduates who have made this evening's discussion even better by actively answering in the chat box today. So thank you, everyone. Good night.
Thank you.
The next
program. I must thank Dr. Sundar sir, a team of MUJ, who a nice case bringing, and Dr. Shishaila, Dr. Ravichandran and team very nicely brought out the interesting case. Thank you, sir.
Thank you, sir. Thank you. Thank you, sir.
Thank you, Shishaila. Yeah, good presentation. Yeah, you should go methodically. If it is a older child, then they will go step by step. Okay, respiratory system examination. You should practice in an older child the inspection, palpation, percussion, auscultation in a methodical way. Okay. Thank you, my co-experts, Dr. Varsha, yeah, Dr. Suman, and also Dr. Srinivas. Yeah. Thank you, Dr. Nagbhushan, sir. Thank you so much, sir.
Thank you, Bhushan, sir.
Thank you for the opportunity.
Gentle reminder
and
for
all
the
DIP.
next program.
Thank you,
Gentle
sir.
reminder
Thank you,
on.
Dr. Suman, yeah.
Thank you, sir. 22nd, we have the next program, which will be presented by JSS postgraduate, moderated by Dr. Ravi from JSS Mysore. So hoping that all of you will join in on that evening as well. Thank you and good night once again.
Thank you, sir.
Thank you. Thank you, Basuraj. Yeah.
Sir, Dr. Ravichandar, we promised we will let you off at 10:30. We did that.
Thank you, sir. My co-panelists were telling, sir, you'll go out to sleep. Please don't sleep today.
I know. That's why we were particular and trying to message you to say that 10:30 is fast approaching. Thank you so much.
Very much, sir.
Thank you, sir.
Please join
Thank
us
you,
for
sir.
the other meetings also.
Definitely, sir.
And
Sure, sir.
encourage the students. Thank you.
Sure, sir.
Sure, sir. Thank you.
Thank you,
Good
sir.
night.
Good night, all of you. Good night. Thank
Good
you.
night. Good night. Good night.